Hi, in this video I'll be telling you a little bit about me, my background and training, and how I got to where I am. I was born to an English mom and an American dad in Cleveland when my father was doing his residency at Case Western Reserve. I grew up in Rochester, New York. After I graduated high school, I went to England and did a year of school over there, and then started at Mount Holyoke College in New England. I majored in English and biology, and after that went to medical school at SUNY Buffalo, State University of New York at Buffalo, which is now the Jacobs School of Medicine. After medical school, we do a residency. I did my residency at the University of Rochester Medical Center at Strong Memorial Hospital. And then I did 2 fellowships, one in hematology oncology and another one in health services research. My research looks at what people bring to medical care, what the system brings, and physicians and other members of the care team bring to that encounter, and then how the whole system fits together to determine healthcare and health outcomes. So if you watch our other videos, you know a little bit about how we're interested in the health of populations, not just individual chipping away at improving health. For fun, I play the piano, I write poetry, which you don't really want to read. I'm a professional coach. I help people who are stuck in different areas of their life and want to get unstuck. I have a husband and 2 daughters, both in their early 20s, both students at the University of Michigan. And my husband and I have Daisy the Wonder Pup, who's a terrier mix, about 2 years old, who goes with me everywhere and sleeps on my lap whenever I'm sitting down.
So breast cancer, never thought I was going to be a breast oncologist. But when I was in training during my fellowship, there was one other fellow and me, and we would give a talk every other week to the faculty. Because as you probably know, you learn more when you teach. So we would teach. And up came my topic, which was the adjuvant treatment of breast cancer. I had no idea what that meant. I was already a full-fledged licensed physician. So I learned, and I learned a lot. And I realized I felt like this calling. I wanted to help people make decisions under conditions of uncertainty. And that's basically what we're doing when we're deciding, does somebody benefit from chemotherapy? Will they benefit from trastuzumab? Will they benefit from endocrine therapy? Or maybe surgery and radiation are all they need? And I realized that meeting with people going through that and their families, meeting with their friends, it was a chance to be with people at a hard time in their life when they didn't know where to go, and that I could, in a way, help them make an informed decision. That was my job as somebody who doesn't do surgery, and I could help them make a decision that was true to their values. So highly informed decisions that are concordant with your values. What's important to you today, next year, 5 years, 20 years, 40 years down the road? That to me was a privilege. And to say, I don't know any more than you do, what do you need to know from me? And how can I help you get through this? And that's been such a privilege to be a breast oncologist and to help people through some difficult times, and then to celebrate with you, of course, in the good times. And that's important that we do both. My research, that story is interesting too. When I was in training, I learned that although a little black girl was less likely to get breast cancer than a little white girl playing in the schoolyard or in kindergarten together, but more likely to die of a disease she was less likely to get, it just felt unfair to me. I suppose it was sort of childlike in a way to say, that's not fair, right? That's what we say when we're little. And it isn't fair. And so that became my heart song, understanding why that was the case, really getting down into the nitty-gritty of treatment differences and disparities. And then as I've gotten older, moving into how can we disrupt that? How can we address that? And that led me also into looking at chemotherapy dosing in people who are heavy. And we know in people who are heavy that until 1985, doses were reduced in clinical trials after that, in clinical trials, they weren't, but doctors didn't catch on. So I'm really passionate about spreading the word that we should use your actual body size when we calculate your chemotherapy doses, especially to start with. We can always adjust and tweak them as we go, but your first dose should be based on your actual body weight. That's another fairness issue for me. More recently, I'm working in the state of Michigan to improve care, working with all the practices in Michigan to improve care for all patients, independent of their insurance, independent of where they live, who they go to, whatever kind of cancer they have. And that's been such an honor to work with doctors across the state. And of course, we spread our work nationally and internationally so that every single patient gets the best care possible. And that just really lights me up as well.
I just love working with Yerbba, and I hope these videos are helpful for you.